So it's my pleasure to welcome Dr. Fairooz to the session and to deliver her talk, keynote address. With pleasure I tell you that she heard her MBBS in Thrissur Medical College. And she'll be talking on okay, over to you, Dr. Fairooz.
Good morning, everyone, and I'm extremely happy to be here today. Thank you, Rajni ma'am, for having me here. She's my teacher. She has taught me all the basics of ophthalmology in Thrissur Medical College, where I started from. And it's been wonderful listening to all the speakers with excellent talk over here. It's an honor, it's a privilege, and thank you to KSOS. I'll be talking about orbital inflammation, challenges in diagnosis and management. And the topic and the title of this entire session is Pandora's Box. And you can find this Greek goddess, Pandora, who's trying to open the box. And most of the time, as orbital specialists and ocular oncologists, we do get a lot of surprises in the orbit. And that's what I'm going to take you through. I have no financial disclosures or interests, and these are my affiliations. So orbital inflammatory disease, basically it's classified by Rootman into specific and non-specific. Most of the disease is usually specific. You have to look for any, etiology which is relating to this orbital condition, whether it could be granulomatosis, it can be transitional lesions like Kimura's disease, Sjogren's disease, even infections sometimes, and vasculitic disorders like Wegener's granulomatosis. Non-specific are those which is non-neoplastic, which is non-infectious, space-occupying orbital lesion, which doesn't fit into A to Z. It doesn't have an etiology, and that's why we call it idiopathic. I'm going to take you through certain important cases which actually taught me a lesson as well. This is a 45-year-old lady with a swelling in the left eye for 1 month, painless, gradual progression. And as you can see here, she has enlarged lacrimal gland. She has enlarged lacrimal gland in the left eye as well as in the right eye, which is slightly less than the left eye. So what do we do next? We went and did a CT scan where you can find actually a bilateral lacrimal gland involvement, although the patient had only complaints in the left eye, and significant enlargement of lacrimal gland in the left. So what do we do next? Do we put her on steroids, or do we go and do a biopsy on her? Well, so I was not too comfortable regarding the age and the bilateral presentation of this inflammation, so decided to go ahead. So I have this video over here of this particular case, and this is how extensively, it's actually how extensively we do this incisional biopsies in orbital inflammation, be it a lacrimal gland or be it an orbital tissue. So this was a lid crease incision, a cosmetic approach basically. In fact, the transconjunctival approach was very good, but in lacrimal glands we kind of avoid it because we don't touch the palpebral lacrimal gland because it can cause dryness because of the ductules being affected. So it's a cutaneous approach, lid crease, layer by layer. So, this is the septum which is being incised, keeping it blood-free as much as possible. The tissues are dissected very gently, gentle dissection, in order to expose the lacrimal gland. And so when you open the septum, the lacrimal gland, which is quite enlarged, pops out. Okay. Now what I want you to see here, even as a general ophthalmologist, it's not a very difficult technique over here. The thing is, how do you take the biopsy? So the biopsy that we take goes for microbiology and it goes for histopathology, both. And microbiology, it goes for fungus. So this is going for bacteria and fungus. And this large chunk goes for pathology. So in fact, a gene expert for tuberculosis was also sent for this. So fungus and tuberculosis, the two microbiological evaluation that we do, and of course the pathology. And it's closed, and so the lid crease is closed, and this is my resident doing a beautiful job on the closure. We did all these things, and the pathology came as non-caseating granuloma. It showed epithelioid cell granulomas, multinucleate giant cells, which was in fact going in favor of sarcoidosis. All right, tuberculosis was ruled out. We did a gene expert test also. So this was a patient again who requires a systemic evaluation. We don't stop there. So we want to rule out any other systemic involvement, and she did have hilar lymphadenopathy. The serum ACE was also increased. So this is the amount of actually investigation in the management, starting from the clinical evaluation to finally reaching to the diagnosis that is done. And she was treated with oral corticosteroids with a very, very, very slow taper along with the pulmonologist. And this is a case of a systemic sarcoidosis with a lacrimal gland involvement. So the lacrimal gland involvement in systemic sarcoidosis is around 7 to 16%. So whenever a patient comes with dacryoadenitis, you should image them, and also if it is bilateral, think of a biopsy to rule out the diagnosis for a specific disease. Now this patient was actually biopsied elsewhere and was referred to me for treatment for idiopathic orbital inflammatory disease. All right, I'm going to show you, okay, so this is a CT scan, a very diffuse involvement of the inferior orbit, and they wanted me to start the treatment of for idiopathic orbital disease. But you know what, I just went and did a very detailed anterior segment evaluation, although we do it in every patient, and this is what I found. All right, there's a conjunctival granuloma. So the diagnosis is right there. So it was a case of orbital sarcoidosis where the histopathology was not looked into in detail. And again, she received oral corticosteroids. So even certain subtle anterior segment evaluation can actually give you the clue to the diagnosis. I didn't go for rebiopsy of the orbit at all. Next is vaginous granulomatosis. So this patient came with bilateral pain, severe pain, ptosis in the right eye, puffiness in the right eye, more than the left eye. In fact, we evaluated her, and this came out to be a vaginous granulomatosis, and in fact, she had nephropathy. So we all know that vaginous granulomatosis is a small to medium-sized vessel vasculitis, which can have necrotic granulomas, and it can also affect the eye. Various layers of the eye, episcleritis, there are various things that vaginous granulomatosis can present with. Well, 50% is the ocular involvement, and in fact orbit is the most common, orbital involvement is the most common among the ocular involvement. So this is a very interesting case, a very good learning case for me. 48-year-old lady complains of watering. In fact, she was sent to me for a DCR, okay, 4 months. OD swelling of the light eye, on and off, inflammation and stuff. History of nasal block and allergy, and she has recurrent sinusitis for many, many years. So the ENT specialist has found out that she has got a septal thinning, and there is necrosis of the septum, and she's on treatment with the ENT. So when this patient came, you can see here there is puffiness in the medial canthus. There is in fact actually a swelling over here. I was not too comfortable about the case. In fact, you know what I thought? With the necrosis of the septum, probably this could be a vaginous granulomatosis. Vaginous granulomatosis usually affects the upper respiratory tract and the lower respiratory tract in the system. She had a strong family history of cancer, father, mother, grandmother, and maternal aunt. Well, I went ahead doing a biopsy, and this was the biopsy that I took, and this came out to be a natural killer T-cell lymphoma with the systemic involvement. So natural killer T-cell lymphoma, in fact, always, it's called the midline granuloma. It affects the nose, the nasal septum, and she also had a nasal polyp, and that was removed by the ENT. So it comprised of 1% of non-Hodgkin's lymphoma. So these are all the specific disease which can actually start and come to you as an orbital inflammation. But then